Welcome to Infectious Laughter Podcast,
where real, ridiculous, and relatable moments from working in healthcare are shared.
We respect HIPAA because it's real, and we like our licenses. Now let's do this with culture and sensitivity. Welcome to episode 4-ish, Nancy.
Of Infectious Laughter.
Ta-da! Yes. And what can I say, Nancy? We're nurses and we're trying to figure out some serious technology today.
Yes.
Yeah.
But as nurses, we figure out machines and technology all the time. So it's just a process.
Right. And then we just had the lovely people at the Orange County Library where we're recording have an audio expert come in and agree with us that their little manual was missing steps.
Yes.
So
we don't feel so bad.
We continue to change the world.
Yes.
Yeah.
One step at a time.
Right. And she looked relatively healthy. All right.
So what are we talking about today?
So I think we should talk about the stuff you need as a nurse.
There's lots of it.
And the stuff that I use as a nurse practitioner.
Mm-hmm.
Like we walk into the hospital, and if we forget these things, we have to go back to the car.
Or my locker. We have a locker.
So you have a locker. I don't have a locker.
Right.
So that's why, like, when I'm walking around with a water bottle and I get in trouble and I'm told to put it in the break room, I don't have a break room.
That's true.
Like, each nurse has a break room in their unit or on their floor.
Yes, and also in each pod we have a nutrition room, which we have also labeled a hydration station so that the nurses can keep our water bottles in there. But that's also snacky items for the patients, crackers, juice.
Right, so like if your diabetic has a crashing sugar and you need to give them something.
Well, technically we give them something out of the medication cabinet so that it's a glucose measured liquid that we give them. Yes, if somebody is crashing but they're alert and able to swallow, a lot of times nurses give them juice, which with evidence-based practice has shown is not what we should do.
So then why would we give the patients crackers and juice?
Well, if they're just hungry and the meal hasn't come yet, we can do that. Usually the people that ask for that are the diabetics. And the juice and the crackers together, usually they want graham crackers, adds up to about anywhere from 14 to 25 carbs, which, of course, then by the time we do their blood sugar before lunch, has spiked it too high. Yeah.
So, because when I was in school, very long time ago, as to get my RN, there was like the liquid you're talking about. It was almost like icing.
Mm-hmm.
And
yeah, it's a gel.
Yeah.
Yeah.
So, but that was like, you only use this if they're crashing. If it's kind of lowish, you use orange juice.
Yeah. Evidence-based practice now says no because there's really no way to track that.
Right, like the actual quantity.
The glucose is monitored because it comes out of the medicine cabinet. You scan it. They know exactly how many carbs are in it, and so it can be monitored. If their blood sugar is crashing and they are not alert and oriented, then of course we do the IV D50 or dextrose 50. Dextrose is a type of sugar. Anything ending in OSE is a sugar. And again, that can be measured because we're either giving them 25 mLs or 50 mLs based on their blood sugar.
Okay. So anything ending in OSE, that is a intervention that a nurse gives, because like Rose ends in OSE, and that doesn't help you.
Yeah. I that they would be very surprised if I gave them a rose.
I'm just saying,
Yes,
if somebody's listening to this,
you are correct,
and had the reaction that I had, which was, I'm going to think quickly in my head what else ends in OSE to disprove you. that's the way I am.
A rose would be a very nice gesture.
I mean, imagine there's a little carbohydrates in there, but probably not a good thing to eat.
No.
Yeah.
Any food item that ends in OS. Lactose is the sugar in dairy products.
Yeah, and you're doing the typical nurse thing, which is I am now going to educate you on all the OSEs. Yeah, I like it. I like it. So, like, really, that snack room, so to speak, not needed, per se.
Well, I wouldn't go that far. You know, we get patients from the ER. Sometimes it's 5 a.m. They have not eaten all night. They have a diet order. We need to be able to give them something. We don't have a full meal at that time, so we might give them graham crackers and peanut butter and some juice.
Yeah, okay. So that's fair. That's fair. I feel like when I was at RN on the floor, I mean, we had like sandwiches and all that stuff, but I imagine that got kind of abused at some point.
Yeah. I think there are still sandwich boxes or snack boxes, but they don't stock them every day on our unit. They do have an anytime menu. I don't work nights, so I'm not quite sure how that works.
Oh, yeah, I've seen the signs.
Yeah.
Yeah.
If somebody has a diabetic diet, they often get a snack that comes up with the dinner tray. It's in a little brown bag, and we put it in the fridge so that the night nurse can give it to them, you know, bedtime. And I think it's usually like a little sandwich and an apple or something.
Right, like a healthy little snack
Right.
Sure. I'm just like staring at the thing, and I see a great sound wave for you.
And not one for you.
No. So we'll check that later.
Okay.
And we'll figure that out because we're figuring stuff out.
That's right.
Yeah. Let's get back to like what I meant to talk about.
Yes.
And I went down another like rabbit hole.
That happens.
So what you need, and if you realize you don't have it, for me, I've got to run back to my car, potentially even run home.
Mm-hmm.
And you've got your locker, you've got your car.
Right.
Yeah. So my list is shorter than yours. I'll say that.
Okay.
So briefly, during the height of COVID, I had to think of the number every day, which...
The number of what?
Things that I had to have on my person,
Mm-hmm.
and I literally counted. So, like, number 1 was my car keys were in my left pocket. Number 2 was I had a pen in my right pocket. And those were in my pants, like those side pockets.
Mm-hmm. Cargo pants?
Yeah, like nursing pants, right? Like scrub pants.
Yeah.
So, for sure, during COVID, most of the providers were like all in scrubs. We were doing laundry like nobody's business. Yeah. So gone was
some of the providers never went back.
Like me, except for when I'm in the clinic. Yeah, like if I could work in something that feels like pajamas and I don't have to have a complex laundry and a big bill, works for me. So then my other thing was in my scrub top pocket on the right was my phone. Okay. So then I would come to my left chest wall, and it was my ID. So that's number 5. Number 6 was my stethoscope.
Mm-hmm.
Number 7 was my mask. So it was 1, 2, 3, 4, 5, 6, 7. And if my number was off, I would try to realize what number it was. Right? Because, I just would count. I didn't say, like, left pocket 1. Right? And the reason I had to do that is the number of times I would get to the hospital door and not have my ID on me because I had taken it off to wash laundry or whatever, or I left my stethoscope in the car or my pen.
See, I have to frisk myself after work because as a bedside nurse, I end up with all sorts of things in my pocket like alcohol wipes, saline flushes, things that I don't want to take home with me because I have no use for saline flushes at home. So when I get to my locker at the end of the day, I check all of my pockets and remove the stuff I don't need. I have a little bag that I take with me to work, and I've been a bedside nurse for 30 years, minus a few months for other stuff. Pardon me. But this bag has collected all sorts of things that I might need. And about once a year, I do find things that I haven't used in a long time I do use. I have a little list of the various things. Now, stethoscope, absolutely, I need that because I do my assessments on my patients every day. Pens, and I have pens of many colors because when I take report, and when I used to work more than one day in a row, I'm part-time now, I would keep the same report sheet, and I had things color-coded so that at the end of each shift, I was reporting back what happened on that shift. If you do your report all in one color, if you've worked 2 or 3 days in a row, things get confusing. So I have many colors. Highlighters, that's mostly for discharges. The discharge paperwork, I highlight the important stuff that I want to go over with them.
So things for the patient to remember, and they see it quickly because you highlighted it.
Right.
Okay.
Pen light, for checking pupils and various things. Throats, when people say they have a sore throat. I have 2 Kelly clamps or hemostats. I have straight and curved. I literally don't use those very often. Mostly I use them for when IV connections are so tight I can't get them off. So I use it for traction. But occasionally a doctor will be doing a procedure at bedside and they're like, hey, who has Kelly clamps? And I'm like, I do.
Yeah.
I'm probably the only nurse on the floor that has them.
Do you have any of these items with you?
I don't, because I keep my bag in my locker at work.
Oh, yeah. Okay.
I wouldn't take it home every day. I just keep it in my locker.
I think it would be funny if you tell me what you have and I see if I remember what it is and can think of what you use it for.
I can bring it with me.
No, read your list.
Calipers.
Calipers. So you're using those to interpret EKGs.
Yes, and more often the telemetry strips that we get twice a shift. Because the EKG will actually tell you the rhythm and what's going on. But twice a day we have to interpret the telemetry strips. Telemetry is the heart monitors that the patients are on. And then twice a day the monitor techs print out a strip of the patient's rhythm, and we have to interpret it.
Okay. I will say from a provider standpoint, when the EKG is printed, it is frequently wrong.
Correct.
That's why people who are good at EKGs and, are interpreting those, like the cardiologists or the primary care or whoever, they want their calipers on them too. So yes, ding, I got one.
I have a multi-charger.
Well, I imagine that would be to charge your things.
Yes.
Like your phone and what else?
Sometimes patient phones.
Oh.
Because they forget chargers.
Okay. And you keep it with you at the desk. You're not giving them, or are you?
No, I keep it at the desk. I have a little desk fan, which I bought on Amazon for about $12. Best $12 I ever spent. When you're running around, when I sit down at the desk to chart, I have my little fan with me to keep me cool. Interestingly, the night shift nurses will often bring a little space heater.
Oh, you know what? I saw a space heater today. It was on your unit,
mm-hmm.
and I had to sit at this one computer that I don't normally sit at because I had to put in some orders, and I wanted to be sitting and not at the standing areas.
Mm-hmm. Mm-hmm.
And I was like, why? In God's name, is just so hot right here.
You must have been there early.
There's a fan at my feet. And so then I look at the fan, and I see it's a space heater.
Yeah. So night shift brings their space heater because they're always cold. Day shift, we bring our fans because we're always hot.
Okay.
And that has been, since I've been a nurse, this has been the way.
When I worked nights in the neonatal ICU, we were cold, except my one coworker, Daisy, told me when she was pregnant with her twins, she would sit in front of a big fan and sort of lift up her scrub top and just let the breeze go. Yes. When obviously, the parents and things weren't there, or she was on break or whatever. But yeah, okay. So what else? All right, give me something else.
A piggyback hook.
A piggyback hook. So piggyback would be IV systems where there's like 2 bags.
Mm-hmm.
And are you hooking the bag on the IV pole?
Yes.
That's what the piggyback hook is?
Well, the IV pole has hooks. However, when you're piggybacking, say, an antibiotic onto IV fluids, whichever bag is highest is the one that's going to run. So you want to, once you put it through the IV pump and get it ready to run, the IV fluids have to go on this. It's a plastic hook that comes with the tubing. I just keep extra in case. You have to hang the IV bag onto this hook that's about a foot long so that it hangs lower than the secondary or piggyback IV, the antibiotic, so that one is higher, and that's the one that's going to run in. It's physics.
I mean, yeah, don't look at me like I don't know what you're talking about. I'm picturing it in my brain, and I'm trying to think, well, what questions would somebody have? So the thing I came up with is, are the IV fluids still going at all during the time that the antibiotic is also running?
No. Because the antibiotic is piggybacked onto the IV fluids, during the time that the antibiotic is running, the fluids are not. Unless, like if the antibiotic bag was big, like 250 or 500, you might run that through its own channel in the IV pump with primary tubing. Then you wouldn't have to worry about how high it hangs because the pump is regulating it. But if you're truly piggybacking it onto the IV fluids stop during the time that the piggyback is running. And once it's finished, it automatically, because there's nothing left in the smaller bag, the IV fluids resume.
This physics, Nancy.
Yes, it is.
So, but when I think of piggyback in the normal world, I think of, my kids were little or my goddaughter right now. And if I put her on my back and she's getting a piggyback ride and I start moving, we are both moving.
Yes.
I don't know why they call it a piggyback.
Because it's not running separately. It's literally hooked into the same tubing as the IV fluid.
But it runs and the other one doesn't run.
Because of physics.
I get that. But even if I take my goddaughter and I hold her above my head and I move, I'm still moving. I'm just saying.
Yes.
Like the term, I don't have a better term.
I don't know where it came from. It's been around forever.
Yeah.
Used to be we didn't have IV pumps.
Yes, I sadly remember that, and you had to count the drips to get the rate.
Right. But that was when it's really important then, whichever bag is higher.
100%.
Yeah.
Yeah. So, okay. So you have an extra piggyback hook in case you don't have one that you're happy with.
Yes, and sometimes they come in handy if I have to kind of jury rig something. It's just a plastic hook, so...
Ooh, tell me things you've been jury rigging, Nancy.
Oh, I have to... I can't think of something off the top of my head, but when I do, I'll let you know.
All right, we're going to put a pin in that.
Okay.
All right, give me some else.
Amiodarone filter.
Well, amiodarone is a medication you're using to regulate heart rate.
Right, it's a vasoactive drip, or it's a cardiac drip. And it requires, you must put a filter between the bag of amiodarone and the patient in the tubing, in line.
But when it comes up from pharmacy or it's in the little drawer that you guys use?
It does.
It has a filter.
They do send one up. But sometimes they don't, or the patient goes down for a test, they come back and somehow the tubing and everything is gone. I just keep an extra one.
All right, you're the lady with the extras.
I am.
Because you're a little extra at times, Nancy.
So I've been told.
Okay, give me another one.
A Christmas tree.
Oh, okay, wait. I remember this from school, and it's obviously not, a Christmas tree. Oh, my gosh. And it's not the little thing with the caps.
No.
And it's not... Is it like a multi-connector?
Not multi. They used to actually be green. They're clear now. It's the connector that you hook up a nasal cannula to the airflow,
Yes.
the oxygen.
Oh, they were green.
Yes.
Yes.
They're no lot. Lately, they've been clear, but they're shaped like a Christmas tree. They used to be green. Everybody called them a Christmas tree. The actual name for them is a nipple connector, but nobody uses that term.
No, if you tell a patient you're bringing in the nipple connector, they might check themselves out. Right. But it's upside down,
yes.
and it looks like an upside down Christmas tree.
And that is how you connect the nasal cannula for the oxygen to the airflow, to the flow meter.
I desperately want to dare you to call it a nipple connector one day and let me know what happens.
Will do.
But, you got to be careful. You do that too.
You have to read your audience.
Yeah. Certain patients are not going to appreciate that.
Right.
It would be fantastic if it was a nurse
that
was a patient.
Because, most nurses don't know that it's actually called a nipple connector.
I never knew that. Yeah. So, okay. And
if you go to the bin where they're kept, it does not say Christmas tree.
But we're very visual nurses, and we just take it.
Right.
Okay.
So I keep an extra one of those because half the time you get a patient from, the ER and they need oxygen and you go in the room and there's a flow meter, maybe not, but no Christmas tree.
So my other thing to say to you is if you had a student nurse, which you get all the time.
Yes.
And you asked them to get you a nipple connector from...
They would have zero idea what I was talking about.
Yeah. But I want to try something because I wonder how many would ask you what that is.
Everybody.
They would
even older nurses. Because
I'm saying,
everybody calls it a Christmas tree.
But I'm saying the student nurse.
Yeah.
And, they know you're this wealth of knowledge. And if you just said it in that flat, dead bed... Yeah. Would they, say, excuse me, Nancy, what is that? Or would they go to try to find it and then eventually have to come out and say, I can't find it?
I don't know, but we have most of our workforce now are newer nurses since COVID. A lot of nurses just left nursing.
Yeah.
It was in an isolation room, didn't have a couple of things, went to the door and told a nurse who had been there a couple of years, I need a Lopez valve and a Toomey syringe. She looked at me like I had two heads. She had zero idea what those were. Those are common things.
What are they, Nancy?
Well, the Lopez valve is a stopcock used for feeding tubes so that you don't have to disconnect the tube every time you put meds in. It has a 3-way stopcock, and you can turn the valve and put meds and stuff in without disconnecting the feeding tube.
I would have just called that the feeding tube with the connector thing.
Okay.
Okay, and the other thing that you asked for?
The Toomey syringe is the big syringe that now we have something called an N-fit because people, I guess, were putting tube feeding in the wrong place in the body. But it's the 50 cc syringe with a catheter tip that we, would put into the feeding tube.
Yeah.
And then pour either the feeding itself or the dissolved meds into.
Yeah, because the little insert thing is long and...
Right. Not anymore. Now it almost looks like a lure lock, which is the screw-on type of thing. And all of the new G-tubes, gastric tubes that doctors put in are fitted with that end.
Oh my God, Nancy, where were they putting the...
Oh, some people...
Careful, there's words we can't probably use if we're on YouTube.
There were cases where people were putting tube feeding into IVs, which...
How did that even fit?
I don't know.
Okay. I mean, that's not happening anymore.
Right.
Praise the Lord. Okay, give me another thing.
Well, I keep my bandage scissors. I keep them in my bag in the locker, but during the day I have them in my pocket.
Right, because the hospital doesn't give you bandage scissors.
No, and I'm very surprised at how many nurses during the day will come to me and say, hey, do you have scissors? I mean, it used to be every nurse had scissors.
Yeah, I still have my nurses from nursing school that they made me buy.
Yeah.
I don't carry scissors because I'm in and out of so many patient rooms with infections.
Right.
And I tell the patients, because they're like, don't you just have scissors? Because I need to look at a wound or something. Right. And I'll go, no, it'll just get infected. And while that's job security, that's not my goal.
Right.
And then, they're okay with that. But, yeah. And then you clean the scissors, obviously.
Yeah. We have those Sani wipes or whatever they're called that are super duper CHG or not
and
alcohol.
And there's bleach wipes and all kinds of things.
Yeah.
Yeah, okay.
And, of course, alcohol wipes, which I have in every pocket. And sometimes they do come home with me, and I just have to take them back. I don't really use alcohol wipes at home.
But also, we're not really even supposed to take hospital stuff home with us, right?
So that's why I frisk myself at the end of the day.
Well, we'll have to get a video of you doing that.
I actually keep a little stapler in my bag.
Is this still because the hospital runs out of staples or you can't find the stapler?
Yes. And when I discharge patients, I don't want to give them 9 pages
unstapled.
Yeah.
Yes.
So I just keep one in my bag. It uses regular size staples, which I can usually find there. But I don't have to go hunting for a stapler.
Yeah, you're a saint. Okay, give me something else.
Excedrin.
I mean, because all nurses get headaches.
Yes.
And so your choice of treatment for said headaches would be like an aspirin-based treatment.
It's Tylenol, aspirin, and caffeine, so it kind of covers all bases.
Yeah, because when I've had migraines before, a little bit of caffeine actually does help. So, yes. Okay, well, now when I have a headache, I know who to talk to if you're working.
An expo marker or a whiteboard marker, because,
oh gosh,
whiteboards now are very, very important in patient care.
Yes, the number of times those are not updated. So ours, there's days of the week, and you circle the day of the week, and you write the date and who the nurse is and their phone number, their hospital phone number. We don't give our personal phone numbers. The patient care tech, if there's one that day.
Right.
The charge nurse.
Yes.
And some nurses write the goals of care for the day.
Treatment plan. PT sometimes writes their goals on there.
Mm-hmm.
About half the time, there is equipment, maybe a recliner that the family member has been sitting in front of the whiteboard that makes it impossible to get to the whiteboard.
Okay, because, especially, when you've been in the hospital for several days, it's like being theoretically being in Las Vegas and you don't see the sun, even if you're seeing the sun because you have a window.
Right.
You don't know maybe you know where you are, but you have no idea what day. And then when a provider comes to assess your neurologic status and they'll ask you questions like, what day is today? And, let's say the patient says, I don't know.
Yeah.
And so then they go, well, what month is it? And I'll tell you, patients can go from one month to another, but also you just can completely get screwed up.
It's like a casino. There's no windows and no clocks.
Yeah.
So
right in the casino. I mean, we're not putting patients in casino closets and stuff.
No, but especially there's something called ICU delirium.
Yeah.
Which they've been there for a while. They've been intubated. They've been sedated. They don't know what day it is.
And even if you haven't been, you don't feel well. You're not sleeping well.
Right.
So
one of the questions we're supposed to ask is, who is the president? And I remember years ago when it was Bill Clinton, somebody said Hillary Clinton, and I gave it to them.
In the last few years, sometimes people will say, well, my president is.
Right.
And then
Or they'll say, I don't want to talk about it.
Yeah. But sometimes if a patient has some dementia, they can say that as a compensatory mechanism. And
yes, interesting. Dementia patients, if they're in that, kind of beginning stage where they know they're confused and they don't want you to know it, they're pretty good at hiding it.
But even if they're not hiding it on purpose, sometimes I can't come up with a word or think of something, and you can justify that away pretty easily.
Mm-hmm.
And so they can be doing that they're not deliberately deceiving someone.
Right.
But for sure, they come up with ways, and that's why sometimes when family members are like, maybe I thought something was wrong, but
right.
You adapt as things are slowly.
My aunt had dementia, and took a long time for it to progress. But you could have a perfectly normal conversation with her. And when she was in the hospital, she broke her hip at one point, and the doctor came in, told her everything. And when they came out, she was actually at my hospital. This was in California. I said, if you went back in there and introduced yourself, it would be fresh and new all over again, because she could carry on a conversation, but 2 minutes later, it was gone.
Yeah, and you can present very well.
Right.
And your family might pick up on things that other people wouldn't pick up on.
Right.
But all the more reason why updating those boards is so important, and so it's nice that you bring an extra marker.
Yes.
All right, what else?
Safety pins. Those big safety pins. We do keep them in the...
Like the big ones, like the old cloth diaper size ones?
No.
Or the...
Well, no, they're, a couple inches long. I don't want to look for them every time I need them, but I use them mostly when somebody has a nasogastric tube, a tube that goes in the nose down into the stomach. You don't want that pulling out. And so I take a piece of tape and put the safety pin through the piece of tape and tape it to the tube, and then safety pin it to their gown, so that if they move or something, the tube can't get caught on something and pulled out of their nose. Because putting an NG tube down is traumatic enough for a patient and for the nurse.
So I'm trying to picture this, and I'll tell you, the first thing I thought of when you have this large safety pin.
Mm-hmm. It's not like for a kilt.
Right, I got you.
Okay.
A couple inches, right?
Yeah.
Yeah, okay. So please don't tell me, Nancy, that you're giving them an ear piercing and attaching that sucker. That's what came to my mind.
No.
But I'm having a hard time picturing, because if the thing's coming out of their nose and it's attached and going
to, say, a suction canister on the wall.
Right. So you're pinning, but when they move...
No, you give it a little leeway. So you
put
a piece of tape around the tube, and then you safety pin that to their gown with a little bit of give from the nose to where the safety pin is. But this way they can't, turn over in bed and then...
And the whole thing
just comes out of the nose. Because putting... Like I said, the first time is bad enough. You don't want to have to go in and put another one down.
You'd rather have to pull on the clothes, and then they wake up and they know that something's happening.
Right.
Perfect. Okay. Good. So, yeah, we are not piercing people on the regular. Good.
No, not on the regular.
Yeah. I might gotta leave a caveat.
But, the interesting thing is, when you need to start an IV or draw blood, the people who are most afraid of needles usually have full sleeve tattoos.
Yes, I have had a lot of patients tell me that.
Yes.
And they've had a lot of tattoos. And I look at them, I'm like, look at this. And they go, it's not the same thing.
Yeah.
And I said, okay.
I've never had a tattoo, so I don't know. But I think isn't that like a lot of little needles?
Well, I imagine it has to do with pain tolerance, and the mind can control a lot of things. If you've decided you're very afraid of a needle going into your muscle that lasts seconds, but one that is going right underneath the skin. I mean, I've had a lot of people say, oh, that tattoo didn't hurt at all. Mm-hmm. And I'll tell you, Nancy, I have one tattoo, and that hurt like a mamma jamma.
May I ask where the tattoo is?
Yeah, it's on my back.
Okay.
And I got it there not because, tramp stamps were popular, and it's not in the tramp stamps spot.
Okay.
But at the time, back in the 90s, early 90s, that was this popular area. That and the ankle, the lateral, the outside ankle.
Right. I hear that's the worst.
Yeah.
The top of the foot and the ankle.
Right. But at the time, that was very popular. Somebody put a little butterfly or a rose or, whatever. So I knew I was going to get a professional job, and I didn't want to have people see it. And I also didn't want to look at it every day. While I still like it, if I saw it every day, I'd be like, ugh.
It's not really where anybody can see it, is it?
I mean, no, not. I mean, my husband can see it.
Right. But when you are wearing even a T-shirt, it doesn't show.
No.
Yeah.
No. So, I did hear recently from one of the surgeons that I know had a tattoo that said, "This too shall pass." Tattooed. Do you know who this is?
No.
Yeah. Okay. well, I'll tell you who it is later. This too shall pass on his chest.
Yes.
And he's super proud of it and took a picture of himself in the mirror and sent it to his friend, who was also in medicine. And his friend said, while I'm on the phone with you, I need you to put your surgical scrub top on. And he did. And all you can see is the ASS of the word pass. And so now he has to wear a T-shirt under because the scrubs are V-neck.
Right.
Yeah.
And it just says ass.
I mean, I don't know if we can say that word, Nancy. We're
yes.
Gonna,
yes, we can.
Okay.
It's not like in the 60s on TV when you couldn't even use the word pregnant.
Right, but I know...
I mean, I wouldn't drop an F-bomb.
I know some of the podcast places, filter the words.
I don't think ASS is one of them. I'm not sure, but we'll check into that.
I don't know. We'll just bleep you if we have to.
Okay.
Yeah.
If anybody wants to comment on something that they use at work that is helpful, we would love that.
Right. Yeah. Realistically, we don't need the things that we can't read. But you could send it, I guess. If you really think it's
just
important.
Put it in the comments.
Comments, yeah. We have the email, infectiouslaughterpodcast@gmail.com.
There you go.
So, yeah, share with us.
Mm-hmm.
Yeah, we would love, maybe we'll give you a shout out. You never know. Sounds good?
Sounds good.
All right, Nancy. Congrats on another episode where we figured out how to use this stuff. All right.
The technology.
Good job.
The hosts and producers of this podcast explicitly disclaim any liability or loss incurred directly or indirectly as a result of the use or application of any of the content presented. Educational or health-related discussions are meant for general information and entertainment only. They're not medical advice and are not intended as a substitute for professional medical advice, diagnosis, or treatment. Always consult your own healthcare provider for any medical concerns or decisions.
While we make every effort to ensure accuracy, we make no guarantees about the completeness, reliability, or accuracy of the information presented. Medicine is always evolving and content may become outdated.
This podcast may contain discussions of medical procedures or topics that some may find sensitive. Listener discretion is advised.
And most importantly, we laugh with our patients and coworkers, never at them, because nursing is serious work, but it comes with seriously funny moments. All right.
Okay.
All right, Nancy. Welcome to episode. We don't know what this is.
Episode.
Possibly 3, but it could be 4.
Why?
Because if we take that one that was really long and make the airplane 2? 1 too, this could be episode 4.
Okay.
So, does that
episode
sound?
Whatever.
4-ish. Yeah.
Okay. 4-ish.
Ready? So, filming in 3, 2, 1. Okay. So. I'm going to take a pause real quick.
Okay.
Push your microphone away from you a little bit, and I'm wondering if your line will even mine. Okay, now say something. 1, 2, 3.
1, 2, 3. Is that helping?
Yeah, that's better.
Okay.
Okay, so now we're back.
Okay.
Okay, so Christmas tree.
Yes.
Nipple connector.
Yes.